you, and you're seeing the three screens: Dr. Patino, myself, and Mr. Teacher Man Juan Pablo de Leon. And today's show is going to be a little different in that Dr. Patino has asked us to kind of grill him on different questions that we may have. Dr. Patino, what do you want us to talk to you about, or ask you about, I should say?
Well, everything and anything that has to do with being a psychiatrist, working in psychiatry. And the reason I came up with the idea of doing something different really has to do with um, this usually goes from the psychiatrist out in terms of how we diagnose, what we do, how we treat, and so on. But for us as professionals in mental health, we don't always get a good idea of what non-psychiatric, non-mental health people think of us,
Hmm.
what kind of concepts they have about us, what is um, the perception, and not only individually from the two of you, but from the people that you are with. And of course, you guys move in different arenas, different types of people, different age groups. So, shoot, whatever you want to ask, I'm here.
Well, I know Juan Pablo. I don't know about your side. I've had people say that psychologists are head shrinkers and psychiatrists are pill pushers. What's your take on that, doctor?
Yeah, I think that I've kind of had that same experience, right? Especially with parents who are very adverse to medicating their kids in situations and things like that. So I've had a similar thought process.
Okay, that's a loaded question.
Sorry, it's my job.
But I'm going to try to spread it out a little bit so we can understand that psychiatry and psychology is really not about photographs, it's about movies, right? So I think that psychiatry and psychology has evolved somewhat by social and cultural pressures into having answers we don't have, right? So we have to start from the idea that behavior is complicated. And if we want to separate it, we have basically two or three different aspects of it that we're always paying attention to. And these your biology, genetics, history, symptoms, your psychology, meaning your temperament, where you were born and what personality you developed. And then you have your cultural background and your social interaction, right? So if you want to understand behavior, you have to look at it from those three perspectives. And now, when I train, I'm talking about 30 some years ago, we used to be trained in all three areas, right? We were, and actually, back in those days, it was a lot of Freudian psychoanalytic theory, cognitive behavioral therapy was starting. We were getting a lot into the development of personality, and it was the beginning of the biological revolution, right? So, what has happened over the last 35 years is that the biological side got a little overloaded and ahead of itself. What does that mean? It means that we bought the idea that pills change behavior, right? So when parents say, I don't want my kid medicated, what they're really saying is, I don't understand this, right? Nobody has sat down with me and said, what is causing my kid's behavior, right? So we're getting very much into the idea of treating symptoms. And I see it in the hospital all the time. When kids come into the hospital on six different medications, none of the medications is working, right? And the kids still having the same behaviors, and you see the prescribers continually trying to chase symptoms. And what I tell my students all the time is that medications at best reduce intensity of symptoms so you can be as miserable as the rest of us, right? So what does that mean? It means that medications don't treat mental illness. Medications treat the symptoms associated with mental illness. Now, in fairness to psychiatry, it's the same case with diabetes or hypertension, right? People say, well, if I give you insulin, I'm treating your diabetes. No, you're treating the increased blood sugar associated with diabetes. Treating diabetes requires losing weight, exercise, changes in your lifestyle, not drinking heavily. There are a lot of things that you have to do as a human being to be healthy, right? So medications in psychiatry don't make people healthy. They can make you less depressed. They can make you less anxious. They can make you less psychotic. They can make you not have as much impulse control, and have better attention. But that's all they do. They don't teach you anything. So if you were dysfunctional before you develop symptoms and you only treat the symptoms, you're going to continue being dysfunctional after you take the medications, right? Unfortunately, our society is such that we have grown to believe that there are fixes for everything.
Mhm.
And in psychiatry, there's actually less fixes than anything else.
I feel like that's some the this idea that like um mental illness is like a purely biological thing. It's something that like you can't really help. That's something that I notice a lot in my students. Like there's a lot of students who've gained this kind of medical vocabulary where like when I was a kid, kids like with autism didn't really know what autism was. Nowadays you have kids saying, "Well, I'm autistic and that's why I behave this way." And I think that that's a good thing, but sometimes I do feel like kids use it as a crutch at times. Um, is that something that you notice a lot as well in your practice? That like people say, "Oh, well, I have this. Cool. That explains all of my bad behavior. That explains why I can't do this." And rather than seeing it as like a something they need to overcome, they see it as like a general limiting factor.
You see, in psychiatry, like in medicine, everything has to do with how much and how often. And it also has to do with what it's doing to your life, right? So if you want to look more globally and you say, well, I have attention deficit disorder, well, I need to know how much you have, right? How frequent it is, and what is it doing to your learning and to your socialization and your activity with other people. So if we are to be successful at helping the individual grow, right, we don't treat this mental illness in a vacuum, right? We treat an individual in the context of the lifestyle and in the context of the culture and the context of their own biology. So there are kids in which you can explain a lot of their behavior because of their biological deficits, and some who don't, right? Now, I do agree with you that labels are bad. I mean, I've never liked the idea of seeing somebody on the street uh, having a conversation with God in the middle of the street in a very delusional way and say, look, that person is schizophrenic. No, it's a person that happens to suffer from schizophrenia. Okay. So the mental illness things are things you have, but they have to be defined, in the context of what is it doing to you. Whenever somebody comes and tells you, well, I'm aggressive and I like to bully other kids because I have attention deficit disorder, you can rightfully say no, you know, because even in the context of having attention deficit and impulse control, you have to learn choices, right? So let's say that I treat you, right, and I give you medications, you concentrate better, you're less impulsive. You still have to learn how to behave properly, right, in an adaptive, social way with other people. So I hear this all the time with people who abuse drugs, for example. I'm not responsible because I was high.
Mm.
Well, yeah, you're responsible because you got high, right? And your choices have consequences. So we cannot separate our biology from the consequences of the behavior people are having. Now, there are very few cases, and I do forensic work, in which we have people who believe that they killed the devil, right? And they're convinced that the person they killed was the devil. That is pure illness, right? I mean, that's totally irrational and does happen, but that's extremely rare. That is not the rule, okay? So, unfortunately, we tend to look at extremes to define the norm instead of looking at the norm, right?
You mentioned a couple things about people being labeled, perceptions of people with mental illness. I know one of the things that I definitely encounter on my other end of things, and what happened with another school shooting today, is they like to blame mental health and mental illness on the violence we're seeing in our society. So the question I have is, are people who are mentally ill inherently more violent and dangerous than anybody else?
Okay, this is a complicated issue, but let me try to explain it. If you get all the people with schizophrenia, right, as a group, percentage wise, they have a little higher incidence of violent events, right? Not shootings, anything like that, just violent behavior. The problem is that the population in general is a lot larger.
Mm.
So, in terms of absolute numbers, people without mental illness commit a lot more violent acts than people with mental illness, right? Now, what happens is that when we see it happening with somebody who had a history of mental illness, then we tend to say, wait, see, they do those things. But in reality, most of the crimes in the United States are committed by people who don't have mental illness. They may have problematic personalities. With one exception, I think that there is uh, a tendency of people with untreated attention deficit hyperactivity disorder to commit minor crimes,
Mm.
right? More often. The problem is that they do it too often and then they get a rap sheet and then they end up in prison.
So Juan
That's like,
Pablo, how does that affect your side of things in the school?
well, the undiagnosed side of things I think is really important because, um, although labels can be used positively or negatively, um, we see kids who have certain behaviors, and we attempt to explain those behaviors. We could attempt to explain those behaviors by saying, "Oh, well, that kid lives in that part of town." We could try to explain that behavior by saying, "Oh, that kid has, a single parent," or all of these associated factors with problematic behavior, right? We've talked about them in previous episodes. Dr. Patino, you've talked about, neglect, right? Like that's one that I think that comes up a lot. As a teacher, you know, we spend more time with these kids than their parents do. What can we do, um, and just caring citizens around in general to kind of help someone who is going through that? Like, outside of, you know trying to send a kid to get the right mental help, like what can we do? Because I do feel like sometimes, like what you said, Vincent, that um, they blame mental illness, or they blame the closest person to what happened. Like police officers get blamed for a lot of things, teachers get blamed for a lot of things. I feel like the first person to the scene gets blamed a lot, and sometimes the first person to the scene can be a psychiatrist as well.
Yes, I mean, what we're talking about here is a lot of complexities, right? And it's very human to look for simple answers to complex questions, right? Because it makes us feel that if we find the why, then we're going to come up with a solution, right? And when it comes to behavior, because it's so longitudinal, it has been going on for so long, and different intensities, and then it gets activated by certain things, right? A death in the family, father gets put in prison, that shot someone, the kid was sexually abused. I mean, and then you get catalysts that change the intensities and the frequency of problems that we have to be able to listen to the story. Number one, okay, and number two, not try to find simple answers to complex questions, but identify the assets of the person in front of you, right? I mean, I see this. I mean, what I see every day, what I see every day is a lot of uh, sexually neglected, abandoned kids who've been sexually abused and they're getting into drugs and they run away and they've been sexually exploited, And one of the first questions I ask the kids is, okay, because they come in because violence or suicidal behavior or whatever, and I'm always interviewing kids with my students present, right? And I always ask, how did you survive that? In my mind, I'm thinking, how did this kid manage all of this, right? And he's still here in front of me talking to me, and he's not dead. because I have to understand what are the assets that I have to work with so I can build from something, right? And what happens is that we tend to focus too much on the negatives. So there's a couple of things you have to do with the person who's suffering in front of you. And the number one is never feel sorry for them. If you feel sorry for them, they're going to get mad at you, right? Because you're giving them the same message that they believe about themselves. You know, poor you, you're not worth it, right? I don't know how. I mean, so we have to be very careful on how we approach kids who are suffering. And the best way is in a very neutral way. A neutral way means not that you don't care or that you're not empathic to their suffering, but that you don't judge. So, rules: don't feel sorry for them, don't judge them, okay? And ask them, how do you want me to help you? Now, you have to ask listening to their answer, right? You don't ask, how do you want me to help you, walk away? Because what happens very often is you are the first person in their lives who's willing to listen,
Hmm.
you know? And they're lost. They don't know where they want to go. They don't know what they want to do. They'd rather be dead, right? But somebody is standing a hand and say, you survived. You have some assets. You know, how do you want me to help you? And that's part of the problem, I think, with professionals in general, including me, is that we want to be directive, right? We want to tell people what they should do. And before we can tell people what our options are for them, we have to recruit them to want to do it. We have to give them a little ray of hope that things don't have to be like that, right? So it is. I mean, of course, we're trained to do this. I've been doing it for a long time. I mean, there's certain things that you look for, but in general, as a teacher, your listening skills are tremendously important. Now, there's one more thing I have to say, and is that you have to know your limitations. You have to know what you cannot do, right? And the only thing you can do really most of the time is to listen.
So, are you typical of most contemporary psychiatrists, or no?
Uh
And
I
again,
don't.
not for ego boost. Just, I mean, you've been doing this long enough. You sound more like a psychologist oftentimes than a psychiatrist. Juan Pablo, would you agree with me on that?
Yeah, I mean, I feel comfortable saying this. Like I've been a patient of Dr. Patino before, and people who are very close to me have as well. And I know that a lot of times people will, because I've referred people to Dr. Patino because of that specifically, because I hear people say, this person just immediately gave me a diagnosis and wants to treat my, like you said before, doctor, um, my scene that I'm currently in,
Mm.
not the whole movie. And I mean, yeah, I'm not sure if that's typical, but I do notice that the buck seems to stop with you sometimes, which is a good thing.
Well, what happens, and I think that um, there was a time you asked me that question. You had asked me that question 20 years ago,
Mm.
or 15, 20 years ago. I would have said, "Oh yeah, I'm the best," right? But there's a point in your career in which you have to learn to leave the ego aside and understand that it's not about me. And once you learn that, right, whether you're a teacher or you're training somebody in self defense or you're a psychiatrist or psychologist, and you understand it's not about me, it's about them, right? Because it took me a long time to understand that it's not my job as a physician, number one, as a psychiatrist, number two, to fix people. It's not my job to tell them what to do. I don't have answers, but I have the knowledge and the experience to help them find their answers and to give them options. Meaning, this is what you can do. Which one are you willing to do? Versus, you have to take these pills, right? And I had to spend the time helping them understand what I said before. Medication at best, and I usually like numbers, and I said it's going to do a third of the job. It's going to decrease your intensity, but then you need to decide what to do with less intensity because a lot of our mental illness becomes adaptive, right? Let me give you an example. Let's talk about social anxiety. That's the most common psychiatric disorder in the world, right?
Hmm.
A third of people have some degree of social anxiety, half of them very high social anxiety. You see it in the schools all the time. Kids don't want to socialize, they're very concerned what other people think of them, they don't want to speak in public, they don't want to do a presentation. I mean, that's probably one of the disorders that teachers see more often than anything else. However, it's so common that it's never recognized as a disorder, right? But it is a disorder. It's a biological illness. Now,
Hmm.
because you're born with that anxiety, you develop a personality around it, right? So once you get to a certain stage in your life, like adolescence, where there's a lot of social pressure, to go outside, you start getting demoralized because you can't. It's not that you don't want to. It's very easy to say, "Oh, come on, let's go." For these people, it's like having a panic attack in the process of meeting new people, right?
Hmm.
So what happens is that there's been a whole development of that personality around that. So undoing that takes a lot of work, right? So in that particular case, is one of those cases where decreasing the anxiety with medications, SSRIs and some other medications, may facilitate them learning to take risks because they've been socially anxious for so long that even if they're not anxious, it's a risk for them to experience what it's like to socialize. And that is one of the most rewarding things in psychiatry to see these kids, all of a sudden start getting into clicking with other people, starting to meet other people, not worrying too much about what they think of them, and they flourish if you get them early enough, right? But if you don't and you start training them when they're in their 30s, they have a pretty fixed personality, right?
Hmm.
So they may be able to adjust somewhat. So that's where the medication and the facilitation of risk taking becomes important because as humans, we are risk averse, right? Just because of our nature of survival, right? We're only going to take risks if we have to, right? Or if we want to mate, or if we want to eat, right? But outside of that, our biological self is not one that is into a lot of risk taking.
Hmm.
So with that idea of social anxiety, I noticed that a lot of kids with social anxiety, and we were talking about this before air, and I think it's a good topic, find themselves with other kids who have social anxiety and a lot of teen angst, and maybe they're making risky decisions. Um, and isolating themselves, but as a group, like they're coming together because maybe they have shared traumas. And I think that's very different because I find a similar satisfaction in when I get a kid who was kind of shy and they joined the wrestling team as a freshman. And by the time they're seniors, they're very well balanced. They found a positive group. But just as well, we see adults and all kinds of people of all ages attach themselves to negative groups. We were talking about cults and people with kind of toxic mindsets and things like that. Do you notice a lot of that in your practice?
Absolutely, but I think that one of the mistakes we've made in psychiatry, one is to try to minimize it to biology. That was a big mistake, and I think that there's a whole movement on trying to undo that and understand behavior. Even though everything comes from the brain, we don't know enough about the brain to pinpoint specifically which areas of the brain are causing any specific behavior. But we do know that there are ways to reduce intensity and frequency. For me, it becomes very important to be able to define purpose, you know, and that's where we kind of miss the boat because if you only think biologically and you have somebody with severe depression, lack of energy, lack of motivation, lack of interest, sleep problems, appetite problems, not wanting to get out of the house, suicidal thoughts. You say, well, I'm going to give you medications to reduce those symptoms, right? Okay, what's the purpose? The purpose always has to be that that person can live more adaptively, whether it's a child, an adolescent, so you can balance it. So when I use the phrase, so you can be as miserable as the rest of us, that's what I mean. Because people who feel bad think that the other side of that rainbow is happiness. No, the other side of the rainbow from being depressed and anxious and psychotic is balance, right? Happiness is like the cherry on top, right? I mean, we have moments of happiness. We don't live eternally happy. So the more moments of happiness, the more fun we have, right? But life is difficult. Adaptiveness is difficult. You have to get up in the morning, and half of the people you probably know don't like what they do, right? But they still go and do it, right? And they come home and have dinner and maybe have a good relationship at home, and they go to sleep and go to work and they go to the weekend. It's a very monotonous adaptiveness that we continue with our lives. So the purpose of treatment of mental illness shouldn't be happiness, should be contentment. I'm content with my life. I'm content with what I'm with. I'm content with what I have, right? I'm content with what I give based on your own personal values, right? But we get, I mean, and I see it all the time with younger doctors and psychiatrists because they call me all the time in the hospital and say, you haven't increased the medication on this kid. No, I have not. Why not? Because there's no need for that. I mean, the medication is not going to make this kid being less abused by dad, right? So you as an outpatient group, what can you do to help this kid, live a more adaptive, content life?
Mm.
And they kept coming back to, well, increase the medications. I'm not gonna over medicate kids, so everybody feels good about it, right? Because the question is not what's in it for you insurance or you doctor on the outpatient basis. What's in it for the kid? And if you cannot answer that question, then you need to move aside and get somebody else to do it because you're not helping. Okay. But that takes time, right? I mean, if you have asked me these questions 15, 20 years ago, I may have given you a different answer, right? Maybe I have drank the Kool-Aid of biological psychiatry, and I thought that Freud was crazy, and that we will find, the panacea medication to fix things. And it doesn't happen like that.
So, do you think all of psychiatry is moving toward that, or again, are you just your viewpoint more unique?
Well, I'm also an educator, so I try to train the people that work with me, even though not all of them are going to be psychiatrists. Some of them are going to be surgeons. Some of them are going to be internists, family doctors, because I train medical students. Others are physician assistants, nurse practitioners, and so on, with the idea of the important thing is the person in front of you. It's not what you know, it's not what medication you think is better. Everybody wants to sit down and have a conversation about this medication versus that medication. And I just pull back and say, wait. Purpose. What are you trying to accomplish? Are you trying to reduce the intensity of symptoms? We can talk about that. But are we trying to help this kid be functional in their lives?
And there's
So,
some responsibility on the patient and the student and the person. Um, and I feel like when, as a teacher, when I give them responsibility, I give them the opportunity to control their fate.
Yeah, and that's very true. And I tend to be very direct with my patients because my patients say they come in and they say, "Well, I'm taking all these medications and I'm still depressed." So, well, but you get up in the morning, you have energy, you go to work, you seek to have a good time with your family, uh, and then you come home and you're miserable at home, right? What's going on at home? Well, my husband is physically abusive, right? And I said, I don't have pills for that. I don't have pills to have your husband stop beating you up. All right. So when you present it like that to them, they you see it's kind of shocking, and I tend to be very paradoxical in terms of how I talk to people. But I tell them, listen, I get paid for what you do, not what I do.
Mm,
Okay, and even if you don't do it, I still get paid, right? So you better get to do it. I mean, you have some choices to make. You want to stay in that marriage or not? But don't come to me and tell me, give me more pills so my husband is nicer, or at least don't feel as much what he's doing to me.
mm.
No, no. But it is hard for a physician in the United States today to say those things to patients because they have not developed a relationship with them. And that's where it becomes important that you know the people you're talking to. Okay. And not be afraid of what they're going to say, not be afraid that they're not going to like you, not be afraid that they're going to say you're being too harsh. You know, I have a responsibility to be realistic to my patients. Right. Now, I'm not going to lie to them. Right. I mean, and I'm not going to tell a kid, you're going to be okay if you go to your home if you take these pills when I know that the situation at home is terrible. Isn't not fair to the patient.
As you said before, it's multifaceted, and Juan Pablo, as you just mentioned, there's a lot of responsibility on the side of the patient itself. There's three of us on the screen in the three areas: biological, social, and the like. And same thing. We have patients, we have their support system, we have their physician. Once again, both of you, thanks for being on the show. And for
Thank
the
you.
audience, when we do these in the future, this is a live broadcast. You can ask questions directly, and we'll do our best to answer. See you
Thank you,
again next.
guys. Take care.
Thank you.